Joint by Dr. Khaja Javed Khan. He is the director and consultant of Algos Multidisciplinary Pain Clinic, Bengaluru. Sir, please.
Good afternoon to one and all present for today's presentation. Today's presentation is on hip denervation, radiofrequency ablation of the hip joint, and how I do it. So let's start off. So this will be the overview of today's presentation of mine. We'll start with a brief introduction, relevant anatomy of the hip joint and the radiofrequency ablation, the procedure, how I do it, and I'll cite a bit of an evidence and we shall conclude. So hip pain commonly we see in advanced age, can occur in young individuals as well, but what is the most important thing is for us to take care of it as pain physicians. We have a lot of options with us. One is the medications, the physical rehab, but what to do if nothing works? Then the next step is going to be the interventions. Now, osteoarthritis of the hip is a very common condition which affects the elderly, and many patients don't want to undergo a hip replacement surgery. So what can we offer them? What option can we offer them? One is the radiofrequency ablation of the hip articular branches. So coming to the hip joint as such, it's a ball and socket joint formed by articulation between the pelvic acetabulum and the head of the femur. Innervation is a bit complex. So anteromedially, it's applied by articular branches of the obturator nerve. Okay, while the anterior portion of the joint capsule is innervated by articular branches of the femoral nerve. Posterior hip innervation primarily derived by branches of the sciatic nerve, and groin hip pain has been thought to be generated by articular branches of the obturator nerve, while the lateral or trochanteric pain is carried by articular branches of the femoral nerve. Now coming to the targets, when you're doing the hip radiofrequency ablation, the targets are going to be the femoral nerve articular branches and then the obturator nerve articular branches. Let's have a look at this now. So how I do it, let's start this video. Okay, so over here what I'm trying to explain is this patient, we are going to do a hip, this patient is a patient of hip OA, so we are going to do the radiofrequency denervation for this patient, and we will be going into the targets. So here you can see, I'll just place this video. So the first target is going to be, as I said, the femoral nerve articular branches. Here we are going to target the acetabulum. I mean the acetabulum, the upper portion over here. This where my laser is pointing is going to be the target for it. So we are going to use a fluoroscopic approach. Of course, I always combine the approach with an ultrasound as well. This is called a hybrid technique, which helps us stay away from the vasculatures. Okay, and here preferably we are going to go from a lateral to medial direction. I'll be playing this video. We'll have a look. Yeah, so you can see the needle over here, which is going to move towards the target. This is the CM shots, and yes, we have reached the target. Now this is the target for the femoral nerve articular branches, as I said, and once we have reached over here, we are going to do a stimulation. As with any RF, we do a stimulation, right? We do a sensory stimulation and a motor stimulation. Sensory stimulation at 50 hertz and motor stimulation at 2 hertz. So we are going to see if it's going to reproduce the pain for the patient around that particular area, and then should avoid any motor twitching of the muscles around the hip supplied with the femoral nerve. Now this over here is a CM picture. Okay, you can see the needle is on the target. This is a cool radiofrequency ablation needle over here, and this is a conventional RFA needle which is going towards the target. So next we are going to go towards the targets for the obturator nerve. Now for the obturator nerve, what we have to do is we have to target this particular area over here, wherein you can see this is the pubic bone and then the ischium. It's called a teardrop kind of location over here where we have to target. And one thing what we have to always keep in mind is here we are starting from below. Over here, as you are seeing, the needle is going up. It is going to go up till over here. Okay, and importantly, yeah, sorry. So this was the video playing. So what we have to keep in mind is whenever you are doing the procedure over here, you have to be very careful because here you are going to encounter the vasculature. The femoral vein is there and the femoral artery is there, nerve as well, but high chances to injure the vasculature. So I always prefer keeping an ultrasound whenever I'm doing, especially at this location, to avoid damaging these structures. So here you can see it has reached this particular target. So one lesion we do over here, of course, definitely after the stimulation, sensory and motor, and and then you can come down over here and do the second lesion. So here you can see the needle. Now here in this video, I'm just going to be explaining the direction of the needle, how it is going to go. We're going to follow a lateral to medial approach, okay, for the hip articular branches, wherein we are going to start laterally and then we are going to reach the target as I had shown. And whereas for the obturator, what we're going to do below you're going to start and then you're going to reach the particular target. Now this is video over here from Avanos, of course, and here we will be seeing the different lesions happening. You can focus over here, needle going in over there and then the lesion happening, okay. And that is for the femoral. Now we are comparing this, and this is the fluoroscopic image over here, wherein you can compare it, the lesion happening, and then for the obturator, from below you saw the needle which came up, and then you're going to see the lesion. This is the three-dimensional view, wherein you can see the lesions happening. So you can see the vasculatures over here, quite superficial. In fluoroscopy, you are not, since it's a two-dimensional image, we won't be able to know how deep we are going. Whereas if we are having an ultrasound, it is always an aid, a useful thing to avoid this particular complication. And as I said, once you're done with the lesioning, below over here, you're coming in, and one more lesion is happening, which will help cover the area. Okay, so I prefer the hybrid technique. As you can see, the ultrasound is over here, the fluoroscope machine is over here. And in the ultrasound guidance, what we're going to do, we are going to be sure to steer away from this area. Here, the femoral artery, the femoral vein, and then the RFA probe, which is coming in. So you can see there's a, almost a 0.5 centimeter gap between the two, right? So if you see the evidence, now this is an article wherein it showed that the RF treatments for sensory innervation of the hip joint have the potential to reduce pain secondary to degenerative conditions, and combining fluoroscopy with ultrasound and multiple stacked lesions, either a cooled RF or a bipolar ablation or conventional ablation, may increase the likelihood of successful ablation of the hip joint. Now, this is a review article from me and Tasar. So this we had written an article on cooled radiofrequency ablation of the hip joint, a boon for the patient, wherein we put across the technique and then how useful it is for patients suffering from such chronic pain conditions. And again, this article also comparing the approach, combined approach, hybrid approach with fluoroscopy and ultrasound. So complications wise, loss of sensation can occur in the cutaneous distribution of the obturator nerve and the femoral nerve as well, the extra-articular sensory loss. Hematoma can occur in the inguinal region because of injuring the important vessels over there. And ablation of motor branches of the femoral nerve can cause problem, weakness, especially in the obturator nerve. When you are doing the ablation, the stimulation becomes very important because you will keep getting the adductor muscles which keep getting stimulated. So you have to place your needle at the exact point so that the stimulations are as less as possible in the obturator region, and then you can start the lesioning. So to conclude, definitely it's a novel treatment option for chronic pain conditions of the hip. Cooled RFA has a larger size compared to conventional RF, and either one, whichever you are choosing, this is definitely an effective tool in the arsenal of a pain physician. Thank you very much for your patient hearing.
So thank you so much for such intricate detailing of the presentation. Because of the constraint of the timing, can I request the chairpersons to kindly share their expert opinion about the same? And we can have the discussions later during the lunchtime.
Yes, all talks were excellent and very nicely presented. I hope that we have learned a lot from these talks. But I want to ask one question from you, Dr. Sir. You have used cooled RF or thermal RF in this?
I've used both, ma'am. I've used conventional RFA also for a few patients, and then cooled RFA also for a few patients. And cooled RFA, definitely the lesion size is more bigger, but the Conventional RF, what happens is, since we are at those closed structures, especially for the obturator, when the vessels are so close by, then it's a small gauge needle, so it's more
Understood.
preferred.
Yes.
Pain provocation, you always get the sensory stimulation?
Sir, in
Strive for the sensory
most of the patients, yes, sir. Especially obturator part, we do get the thing. Sometimes for the femoral articular branches, we may not always get, sir.
Begin the next session at 2 p.m. Thank you.